Good evening, everybody, and welcome to our Live Well Education series. Tonight we have a really hot topic, coping with menopause. I have been appropriately socially distanced, so I'm going to remove my mask now so you can hear me better. Thank you all for attending. It looks like we have set a Tanner record for the number of people who have signed up, and attendings are rolling in as we speak. So thank you for joining us. I am Dr. Bonnie Bowles. I'm a physician executive here at Tanner. I'm the Vice President of Clinical Transformation. That means I get to do a lot of different fun projects, including moderate cool topics with amazing doctors like Dr. Zeller. So let's just go over a few things first. And one is that if you want to ask a question, and we highly encourage question asking, you will select the little chat. Well, it's actually a purple question and answer button in the upper right corner. You should see that, and you'll be able to send questions. It asks for your name in the question. You don't have to put your name, or you can put Mickey Mouse if you want to ask something that you don't want anyone to know you're asking it, but don't be shy. I'm sure that we have a lot of great questions, and let us know if you have any issues, but hopefully you can hear us and see us. Dr. Zeller is in the other room so that we are following our safety protocols. And I would like to invite Dr. Zeller, who is a board certified gynecologist with Tanner Healthcare for Women, to tell us a little bit about herself before we get started with this great topic, which I'm sure we have a lot to talk about. So Dr. Zeller.
Thanks, Bonnie. Let me know if y'all can't hear me. I'm not used to just looking at a computer screen and talking, but I've been in Carrollton since 1999. I was the first female OBGYN. We'd had a GYN in the past, but not somebody who did OB and GYN when I came to Carrollton. So that was kind of different for here. But my residency, I did my residency at Walter Reed Army Medical Center in Washington, D.C. And I was actually the first all-female class of residents, which was very strange for them. I can tell great stories about that, but we'll go on. After I finished up my residency where I trained in OB/GYN, because everybody asked me, what did you do in the Army? I was a military physician and I did OB. I went to Fort Knox. I worked there for 3 years. I finished up my military commitment, and then I came to Carrollton, where I've worked since. I'm married to Dr. Jellicourse and still married to Dr. Jellicourse, although there's rumors all the time that we're not. And we have 3 dogs and 1 cat. So that's pretty much my story. And I'm doing now just GYN only at this point.
Great. Well, thank you. And thank you for agreeing to have this session. So let's go ahead and get started. And remember, questions and comments from you, our participants, are encouraged. So type in the comments section and we'll be watching. I'll be helping navigate those questions and getting those to Dr. Zeller. So Dr. Zeller, what is menopause? And I asked you before kind of jokingly, but why do men get a name in that anyway, menopause? I have a feeling I know the answer, but tell us about that. And it's called the change, or the change of life. I remember growing up hearing that. So tell us what it is.
So with menopause, by the way, I told you before, I do not know why the menopause thing is in there. I'm sure it's something to do with Latin, but I don't know. And most words that we use in regards to menopause anyway, perimenopause, menopause, and postmenopause, which we'll go over in a bit, they are all, a lot of them were developed by men a long time ago. So sometimes things get a little confusing. But basically with menopause, whether it's natural or surgical, either one is when either the ovaries have been removed or they've stopped functioning. And when that happens, the ovaries basically don't produce any more estrogen. And you're born with as many eggs as you're ever going to have. You actually have those before birth. And throughout your life, you continuously lose eggs, and they get older, and you're born with millions of eggs, but as these eggs go away, then you start the perimenopause time. And that's that cutting on and cutting off thing where you might have some hot flashes and you might have some irregular periods, and then you go back to having regular periods. That's perimenopause, and that usually starts anywhere from the age 35 to 45-ish range. It depends for some people, and it will last usually 10 years, that time frame. The average age of menopause, by the way, and postmenopause are the exact same thing. The average age in the United States is 52. So, but some people go earlier than that. I think I've heard the longest anybody ever had a regular menstruating woman was 65 years of age, and I said, just shoot me if that ever happened to me. But so the average age is about 52. It's not the end of the world, by the way, and I'm well past that age, and I can tell you menopause has some plus sides and it has a few downsides.
Yeah, so I think we want to hear about that, because it seems that there are a lot of downsides, but it does seem that there has been a lot of progress, and so let's hear about the upsides. But first, I think you are going to tell us a bit about the typical symptoms, and maybe then we can talk about how to handle those. And again, if anybody has any questions, don't forget to use your purple question button.
So the usual symptoms of menopause, you'll hear about hot flashes. And so until you experience one, because I always thought I knew what they were until I had them, then I was like, oh, okay, that's what that is. A hot flash is usually, you almost feel like you have a little fire inside, and it's usually around the head and neck area. My nurse used to always laugh at me because she would start going, you're having a hot flash, aren't you? Or you were having a hot flash in that room. And I'm like, how do you know? Because your ears turned red. So she always knew, or I'd start sweating and she'd go, you're having a hot flash, or you know. But hot flashes, if they occur at night, are usually called night sweats. I've had people tell me they thoroughly soak their sheets and that kind of thing. For me, it was, I'm hot, I throw the sheets off, I'm cold, I pull the sheets and covers back on. And a lot of that I've learned to deal with is basically have a floor fan and a ceiling fan. And I just basically don't have a lot of covers on my bed, and if I do, like, I'll go to bed at night early and I'll be cold, and I just have to be prepared to be able to take off the flannels and pull on something else, or maybe I'll put a little tank top on and then a flannel pajamas on top, and then as I get hot I take them off, I put them back on, those kind of things. And it does get better over time. Vaginal dryness, I would have to say, for most people, besides the hot flashes, are probably one of the bigger complaints. Vaginal dryness and painful intercourse, because usually our partners are continuing on wanting to have intercourse, and naturally so. And sometimes our partners are given medications for their erectile dysfunction, or they're given testosterone. And so we have to deal with the vaginal dryness, and there are medications that we can use. And there are medications that we can do that are not hormonal. There also is a procedure, it's a laser procedure that we have someone in town who can do called Mona Lisa Touch. And it uses laser therapy for the vagina to help with that painful intercourse. Those are the biggest physical things. Emotional things.
But before you leave the physical things, let's talk about that, if you don't mind. We'll take a pause and talk about the laser procedure. So that helps with pain, but not necessarily with dryness. Is that correct?
It can help with both. Now, I'm not an expert in it because I don't have that device in my office, but it's like most things that when we're using laser, like we're using laser therapy to a face, it works on the collagen level. And basically it's a non-ablative laser therapy. So if anybody's ever familiar with a laser procedure, it's called Fraxel, or I'm trying to think of Fraxel is probably the most common one, where we would do non-ablative techniques to the skin on the face. This makes little tiny micron holes in the tissue and basically causes that collagen level to recoil and gives that layer of tissue some more oomph. And because what happens when we're menopausal, our tissue gets so thin because of the lack of estrogen, that's what causes the dryness, and that also causes the pain because we lose the elasticity in our skin. Because if you ever, some women will say, well, why are those grooves and things in my vagina? Why's my vagina so bumpy? Well, that's because when we're having a baby, we need that to almost expand like an accordion so it can open. Well, as we age, that tissue gets really thin and very not pliable. That's where this Mona Lisa Touch works a lot, but also sometimes we use vaginal estrogens. We sometimes use moisturizers. One of the most common moisturizers, you can get hyaluronic acid suppositories or hyaluronic acid creams, and that's, people put that on their face. Well, they also put it in the vagina to help with that. And then sometimes we have to do just different kinds of, there's also a non-estrogen, but it is a hormone, and it's called Interosa, and it works very similarly to help that tissue.
I think a lot of women are concerned when you talk about hormones because of the incidence of breast cancer and family members with breast cancer. So it's good to know that there are options that are not hormonal options, and even probably non-surgical options.
Oh, yeah.
For lubrication. We have a question that came in, so thank you, Lori, for sending a question in. And you did mention, Dr. Zeller, that I think perimenopause leading up to menopause can last up to 10 years, right?
Yes, ma'am.
But can hot flashes last 10 years?
Hot flashes. So I can just speak from experience. During perimenopause, you will have hot flashes. Now, you'll have times when you won't, but then you might develop some hot flashes for a few days or a couple of weeks or even a couple of months, and then they get better and then they come back. And, it just kind of goes back and forth. Once you go through menopause, you will continue to have hot flashes for the rest of your life. I always joke with people, and I feel like I can say this because I'm postmenopausal. You will continue to have hot flashes even when we put you in the ground and we throw a little bit of dirt on you. There's probably going to be a puff of smoke, but that's okay, because what happens with the hot flashes, they get better. They're less intense. They're not as frequent. So you'll still have them. They just won't be as bad. And I can go, I'll just tell you, when I go on vacation, I hardly ever have a hot flash. When I'm concentrating really hard, or I'm in a hurry, or I'm frustrated, I'll have a hot flash. So it probably has to do with our catecholamines, our, fight or flight mechanism of our body that makes us have that hot flash. And a lot of people will say, I'm trying to get ready in the morning, and I just basically, my makeup just melts. Well, it's because they're probably in a hurry, and that makes a big difference. There are things that you can do to help with that, and it would also probably help with the emotional things too with menopause. There have been some really good studies where they did what they call paced breathing. It's basically deep breathing exercises or meditation. And they've shown that by calming the body, and even doing yoga and those kind of things, actually help decrease the intensity and the frequency of hot flashes. So just even when you get a hot flash, if you just take some nice big deep breaths and just try to calm down a minute, sometimes that will help the hot flash too. That doesn't explain the night sweats. Night sweats are a totally different animal.
Good to know, though. Night sweats interrupting sleep, with my background as a sleep physician, that's very concerning to me. So do you ever recommend sleeping pills or anything to try to sleep through the hot flashes, which we have to be very, very careful with those? Just curious.
So when you're talking about some of the medications that we can use for hot flashes, one of my favorite, and it works sometimes great for some people, is a medicine called clonidine, not Klonopin, but clonidine. Dr. Bowles will know, we used to use that a long time ago for blood pressure. But in low doses,
Are you saying I'm old? Sorry.
No, I'm saying that you probably know about the drug. You did internal medicine residency, I'm sure.
Oh, yeah.
With that medication, what happens is, we're not exactly sure how it works, but on some people, I'll just have them, if that's their chief complaint is night sweats, I'll just say, let's try this clonidine at night. and they'll take it just at night. And sometimes that will take care of the night sweats or decrease it for them. A lot of the night sweats, like we were talking about, you were telling me about those cool jams the other day and the pillow with the pillowcase and stuff. That's another thing. But the biggest thing for me has been, you know, having a floor fan that blows on me, and also have a ceiling fan. Those two things have been really helpful for me for my night sweats. And the other thing, so talking about symptoms of aging, lack of or inability to sleep or having problems with insomnia is not an uncommon complaint in men and women. And there are a lot of different things, like we were talking about. There are sleep studies that are done. Some people think that their insomnia or their night sweats are because of menopause. Well, also can be because of sleep apnea. Your body is under stress and you're having sleep apnea, and so that can be a problem. So I always tell people, if they're really having trouble sleeping, we need to make sure what it's from, and that we're not just covering something up by giving you a medication to sleep. And pretty much, I don't give sleep medications. I will tell people to get some Unisom. Some people try Tylenol PM. Some people like melatonin. But the biggest thing you need to find out is why you're not sleeping. Is it truly that you're not sleeping, that you can't go to sleep, or are you waking up feeling fatigued because you actually never got good sleep, maybe because of sleep apnea?
No,
There's a lot of different.
Excellent point, and sleep apnea does increase in women after menopause. Hey, we have another great question that just came in. So we have someone who's been treated with an estrogen progesterone combination medication for hot flashes, which actually led to periods. And she very appropriately said, that's not fair at all. Can hot flashes be treated effectively without leading to having periods?
Yes, they can. It depends on what your goal is. So even if I'm treating someone, even if I give someone hormone replacement, let's say we're doing an estrogen and progesterone, and I do give them that, I could actually, I can do it in several different ways. Sometimes back in the day when I first came to Carrollton, we had something called Prim Phase, which was Premarin and progesterone, and it was in a pill pack, just like a birth control pill pack. And part of it had a combination, but when you would have a cycle every month. And a lot of people got tired of doing that. And that was the original way of doing it. And then they got Prim Pro, and then they developed other things that were not Premarin. If anybody wants to know, it's made out of pregnant mare urine, and that's how they got the word Premarin, pregnant mare urine, from a horse.
Wow.
And so when you're on those medications, I always tell people, if I've tried every single thing that I have in my armamentarium, and now I'm going to hormone replacement, we talk about, you have a 90% chance of having some abnormal bleeding during that first year. 90%. So you've got to be prepared for it. And that means that you might need a workup to just make sure that we're not causing hyperplasia or uterine cancer or something like that. The other thing is, I was going to say about hormone replacement and any kind of our medications, we may decrease your hot flashes, but we may never make them totally go away. You may always have some hot flashes, but they may not be life altering. So you can still have a hot flash. I can most of the time get them better, but I will not ever guarantee you that you will not have some hot flashes.
Great.
Does that answer that question?
I think so. Please let me know in the chat if that answered your question, if you have other ones. We have another question. Why don't we keep the questions coming, and I'm going to make sure that Dr. Zeller gets a chance to address those, but let's let Dr. Zeller advance through a couple more slides and see where we end up. How about that?
Let me hit a couple of things on this one. So mood swings, anxiety, depression. A lot of this, by the way, I have people on, just for instance, I had a lady who came in and I said, you're going through menopause, and she was like, oh my God. I said, what? And she goes, I'm going to be horrible to live with. And I said, what? And she goes, well, I'm just, people have told me it's going to be terrible when I go through menopause. And I said, well, have I been mean to you? I mean, I'm in menopause and I'm fine. I mean, that's a myth. You're not going to fall apart. But during that time, it's usually we're in our 40s, 50s. Our children are graduating. We're working. We sometimes are taking care of our grandkids. We're taking care of our parents. We have a lot of life stressors going on. And that is what's contributing. And lack of sleep, it sometimes contributes to the mood swings and anxiety and depression. So yes, that you can see that, but there are medications, and just giving someone a hormone replacement is not going to fix those things. I can give you all the estrogen in the world and it's not going to fix those things. I might need to give you something else. And then the other things where decreased sex drive, fatigue, weight gain, those are symptoms of aging and not necessarily symptoms of menopause. Okay, and the reason I can say that is if I surgically remove ovaries, a lot of my younger women, so we have to do it for endometriosis or something, they won't necessarily have those symptoms. So it's something we just have to remember. A lot of people come in and say, I'm getting old and that's why. I mean, I've gone through menopause and that's why I haven't got a sex drive. There are drugs we can give for that. Fatigue and weight gain, that's part of aging. So yeah, we talked about the hot flashes. Does anybody want, and I mean, it's true. 50 to 90% of women experience hot flashes. It just depends on how much it bothers you. There's some people, it's like the squeaky wheel gets the grease. There's some people who are going to tell you about their hot flashes every day. There are other women who just go on with their lives, and I'll say, are you having hot flashes? Yeah, but I'm having hot flashes, but they don't bother me. I'm like, okay, well, that's good.
And do you think that there's something in particular that helps that? I guess I'm thinking of exercise. You said exercise seems to help a lot of it.
Exercise is really good for everything, the whole kit and caboodle. I mean, I think exercise helps with mood. And I was talking to somebody just the other day, and we were discussing menopause, and we were talking about all the things that were going on in her life. And I was going, wow, I mean, well, tell me what you are doing for you. How are you taking care of you? You know, I mean, you got kids in college, you're worried about them, or your kids graduating from high school and you're trying to get them into college. Your husband's got an illness. And I just finally was like, well, tell me what you do for you. Like, are you exercising? Are you? And she told me, she goes, no, I quit doing that. And especially with COVID, so many people have told me I quit exercising during COVID. Well, go out and take a walk and leave that cell phone at home. Leave that cell phone somewhere. You don't have to be on it 24/7. Somebody does not have to be able to get hold of you every single second of every day. And I think that, I mean, I go to the gym every morning and work out, but I just want to get in there. And sometimes that's the best part of end of my day is to get to the gym and know that I can go work out. And for that 30 minutes to an hour, I don't have to think about anything but that spin class or that pump class or whatever I'm doing. And it makes a huge difference, even if it's out walking.
Yeah, I think if people are having issues with arthritis or things that maybe make them feel that exercise is not the answer, there may be other ways to gently get moving and maybe try meditation like you mentioned earlier.
And yoga. I mean, and right. Yoga can be done by anybody. You can do chair yoga. It's fascinating. There's all kinds of different things you can do to just move, keep going.
Yeah, and that's a great point during the pandemic that you can do yoga at home with different YouTube videos and things. But hey, let's look at some of these questions. We're getting great questions. So, Dr. Zeller, what is your opinion on Amberen? Lori has had good results with this for several months.
I think like Amberen, Estroven, all those, and I tell people, you know, go for it. You're not going to hurt yourself with it. That being said, you've got to remember those are considered dietary supplements. And it is okay for you to use them. Just realize that, you know, physicians being physicians, we're going, you know, those not FDA approved. The FDA doesn't watch them to make sure what's in them. But I think if you have a pretty good, what's the word I want to use? If you get a good product that's pretty much middle of the road, like you're not getting it some weird place off the internet, I think you're probably going to be fine. You know, if you're getting it from a pharmacy and it's over there in the supplements, I think that's great. There is a huge placebo effect of anything. I could give you water and tell you it was, you know, going to be the best thing for you, and it's been proven, and probably over half the people go, yeah, my hot flashes got better. But it's a placebo effect, but that's okay. Placebo effects can still be used in medicine, and it's an okay thing for you to use. Black cohosh, by the way, if people will see that on their some of those medications. Black cohosh used to be used by American Indians for hot flashes for for thousands of years. Usually they only used it for about 6 months, but it's okay for you to use it long term, those kind of things. I'm fine with it.
What about wine? Doesn't wine have a great placebo effect? And I'm asking for a friend.
Well, wine for some people can actually make hot flashes worse.
Gotcha.
So if you're not affected by it, a little bit of wine wouldn't hurt you. It's great for your cardiovascularly. You just have to make sure you're in moderation, because it can theoretically increase your risk of breast cancer in large doses. So we always tell people about when we're talking about exercise, and you brought up cancer earlier, probably the top 4 biggest things you can ever do for yourself to decrease your risk, not make it go away, but decrease your risk of cancer. Exercise is number 1. Number 2 is don't smoke. Number 3, maintain a normal body weight. So, and by the way, that also helps. I know when I lost weight, I intentionally lost weight going into menopause, and my hot flashes got better. So when I drop about 10 pounds, I don't have as much insulation. I do have fewer hot flashes. So that makes sense, because you just don't have as much insulation. But decreasing or maintaining normal body weight actually decreases your risk of cancer. And the other one is limit your alcohol, or don't use it in moderation. How's that? Use it in moderation. Don't go overboard with it.
Great. That's great. Thank you. So I have another great question. Beth says, 48 years old and face looks like I'm going through puberty. Huge acne cyst. Just wondering about hormonal acne and menopause.
So my mother lied to me. She always told me my acne would get better as I got older, and still at 57, the other day I had a zit on my face. It was from the mask, I'm just telling you. But I usually, on those things, I usually send those people to the dermatologist, because they have different things for patients to use. I would never, ever tell you that I'm an expert on acne. By any stretch of imagination. When you're younger, a lot of times we will use birth control pills to manage acne and to help with acne. But as you get older, you probably need to see a dermatologist if you're starting to break out and it's just not getting better. And also the biggest thing is make sure you get that makeup off of your face every night before you go to bed. Give it a break.
Yeah, it sounds like it's cystic acne, which is very troubling and is or is not one of the issues with menopause. Is there an increased risk of cystic acne?
It's not really, but you will see. But it's kind of like pregnancy. Most women won't have a problem, but then you'll see those few people who have really bad problems with acne. And I'll occasionally see them, but I'm usually going, you really need to see the dermatologist, because I don't have anything in my armamentarium to take care of that. Right. And the same thing with pregnancy. There's not much you can do for that by OBGYNs. A dermatologist might have some better ideas about what to do.
Sounds like she might have tried that as well. Okay, maybe she can hit me up with some more information if you feel like it on that one. And we got a compliment. Y'all are funny. Thank you.
Good.
How much and in what ways does a partial hysterectomy affect the symptoms of menopause?
So a partial hysterectomy, that I have this conversation every day. So for you guys, a total hysterectomy means taking out the ovaries, the uterus, the fallopian tubes, the cervix. For us doctors, a total hysterectomy means just taking out the uterus and the cervix and the fallopian tubes, leaving the ovaries. We add the BSO part, which is bilateral subpingual oophorectomy, like you care. But if you ever have to sign a consent for surgery, you'll see that and you'll go, what is that? That's where we take out the ovaries. So if you're just having a hysterectomy and we're leaving your ovaries, there are some people who say it can decrease the lifespan of those ovaries, like how much longer they're going to work. And for some people, they say can be as much as 5 years. But I leave it up to a patient if they want to leave their ovaries. And let's say you were 45 years old, didn't have a family history of ovarian cancer. I might say you could leave your ovaries, that's fine. I mean, no big deal. But let's say you were 40 years old and mom died of ovarian cancer, even though you don't carry a gene, I'm probably going to tell you to take out those ovaries. That would put you into menopause immediately. If you leave the ovaries, you will still naturally go through menopause eventually. You won't have the signal of not having a period. So that's our normal signal that you've gone through menopause, and doctors will tell you that a year with no menstrual cycle at an appropriate age usually means menopause. So I have patients who'll come in and they'll say, I want to know if I'm in menopause or not. And I'll say, well, what's your goal? Why do we have this? What do you want to know? I just want to know just to know. Okay, then we can do blood work for that, and that will give us an idea. Occasionally, though, I'll say, well, you're 49 and you don't have a uterus. Are you going to do hormone replacement? Well, no. Well, why do you want to spend the money? It's just a conversation to have with your doctor. Why would I spend the money just to find out if I was in menopause? Just to find out if I'm not going to do anything about it. If you see what I'm saying. But just having a hysterectomy in itself can decrease the lifespan of those ovaries in general.
Yeah, that's interesting. Okay.
Nobody knows why.
Yeah, I did not know that. Thank you.
It's probably because of the disruption, the blood supply that we disrupt when we're doing a hysterectomy.
Gotcha. Okay. Do you want to go through a couple more slides, or are you ready for some more questions? Okay.
Yeah, I'll do whatever y'all want to do. Do you sweat while you're asleep? On that, I will also say, and I don't know, Bonnie, you probably know this, doing sleep medicine, I think people's temperature resets at night. You can go to bed cold, the bedroom's the same temperature, and you'll be hot later. But I think it's natural to have different temperature settings in your body at night, especially in the perimenopause time or in the postmenopausal time. Waking up frequently due to night sweats isn't abnormal. That's true. It's also not. Sometimes I wake up and I think, why did I wake up? Am I hot? No. Do I need to go to the bathroom? Okay, well, I'm probably going to have to get up in a minute, an hour anyway. It's not uncommon for us to have to go more frequently to the bathroom as we age, men and women at night. One of the reasons is throughout the day, we actually will have some swelling and hold on to some fluid in our body, in our skin tissues and that kind of thing. And then when we sleep at night too, that will also wake us up, our bladder filling up, because our body mobilizes that fluid and wants to get rid of it. So you'll sometimes notice that your legs, if you have swelling in your legs are more swollen in the evening, but when you wake up in the morning, you're like, my legs look pretty good, now. Or if you might notice, when you wake up in the morning, you know how your hands are real tight, or your face is puffy? That's because all that fluid that was in your body elsewhere has now been mobilized. Well, it also goes through your kidneys too and into your bladder. So that's another reason sometimes people have to get up a lot at night and we always associate it with being older, but I think that just has to do, I don't think that has to do with menopause. I think that just has to do with aging kind of thing.
Gotcha. So talking about core body temperature when you sleep and exercise, one of the things as a sleep physician that we tell people is not to exercise too close to bedtime. So at least give yourself 2 to 3 hours, because you exercise and raise your core body temperature, and your body's signal that it's time to go to sleep is actually your core body temperature starts to fall. Of course, that doesn't mean that you won't get hot under the covers and flip-flop with night sweats, but you might fall asleep easier if you don't exercise close to bedtime. And the bedroom temperature, if you can, in the summer it may be harder to run things this low, but to keep the bedroom temperature average about 65 to 67, people seem to sleep better.
And not turning on the heat at night, if you can. You'll save on your electric bills, but definitely turn down the temperature in your bedroom at night. It makes a huge difference.
Yeah. So we have another good question actually about sleep. So Yvonne says, I guess I'm pretty much through menopause at almost 58, didn't take any medication, so that's fantastic. My hot flashes are infrequent now, so this is all kind of what you were saying, so that's good news. However, I don't sleep well because I'm wide awake when I should be going to sleep, and I can never seem to get the temp right. Since I've been very hot-natured my entire life, the latter is sort of normal for me. So is my sleep issue menopause or just a result of getting older and sleeping less? So those are really interesting points. I will say that it is not normal to sleep less as you get older. Your phases of the different types of sleep you're in, deep sleep and REM sleep, those change a bit as you get older, but you should still get the same amount of sleep. So that would be the goal. And there may be a lot of different reasons for not sleeping. Dr. Zeller, what would you say to that?
I was going to say too, and making sure you have really good sleep hygiene, which means trying to go to bed the same time every night. Trying not having any electronics, like don't be using an e-reader or looking at Facebook or even a TV, because that can stimulate you to, the light from that can stimulate you to want to stay awake, or your body to want to stay awake. But I think the biggest thing is to try and have good sleep hygiene, and making sure you're going to bed at night, same time every night. But also get rid of things that are, I mean, a lot of us, when we go to lay down to go to bed, we're thinking, geez, what am I wearing tomorrow? You know, those kind of things. Or, you know, I really need to remember, I've got to remember to go pick that blah, blah, blah up. You know, it's not a bad idea just to have a piece of paper and write down thoughts or things that you're going, I really need to remember that for tomorrow. You know, I really need to remember to make that casserole, take that to blah, 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 write that letter or whatever. You can write those things down, or you can also prepare for the next day before you go to bed. I want to lay my clothes out, just like you would for your child or whatever. It does make a huge difference in the morning, and also helps you sleep better, I think, just to be able to do that. And my biggest thing is, and I'm terrible about it, I have terrible sleep hygiene. I'll go to bed one night here at this time and another time the next night. But if I'm consistent, it does help me. The exercise too helps me too, because it gets rid of excess energy earlier in the day. And it also just calms me down, I think.
Great. So another great question, estradiol 0.05 has been transformative for me. Is it addictive?
0.05? No. Now so just so we don't get anybody going, what? Why is she going just that? So it depends on if a lady has had a hysterectomy, and she does not have an intact, as we say, an intact uterus. If she doesn't have a uterus, then we can give that person estrogen by itself. But if someone has a uterus, we have got to protect that uterus, because estrogen by itself, unopposed estrogen, can cause uterine cancers. So, and uterine hyperplasia, but the uterine cancer is the one we're worried about. So it's not addictive. I will say this other thing, when we were talking about the lady before who said that her hot flashes had gotten better over time. When you do take hormone replacement, you have an increased risk of blood clot, heart attack, and stroke. That's just one of the risk of it. As you age, most of us physicians want you to go on lower, if you're on hormones, eventually we want you to come off of them because we don't want to, you're going to have increased risk for stroke. Now we don't want you to have more increased risk for stroke because we're giving you a drug. But the reason why, if you go through menopause naturally and you don't have, you don't choose to take hormone replacement, your hot flashes get a little bit better, is you downregulate those receptors, those estrogen receptors. But if I had chosen to take hormone replacement 5 years ago, I would be putting my body back where it was before. And then when I got to be, 60, and I decided I wanted to stop my hormone replacement, guess what? I'm going through that whole thing again.
Oh, wow.
Do you see what I'm saying? I'm going through that whole thing, as opposed to saying, okay, I've gone through it, and my estrogen receptors have decreased, and so then my hot flashes will get better. But if I move that basically, that whole scheme over here to now when I'm 60, I have to do that whole thing again.
Yeah.
And I mean, just reading back, preparing for this, hormone replacement, I will guarantee you there are some people who it is so life altering for them to go through menopause. They have to do hormone replacement, but there's so many options now that we can do without that. And let's say we do remove someone's ovaries and they're very young. Let's say they're 38 when you have to remove their ovaries. We'll most always offer them hormone replacement just because their estrogen was so high. That would just slam them into menopause. And it's kind of stressful. Now, some of the patients will tell me, can I just see how I do? And I'm like, yeah, sure. But just know I have something here for you if you need it. And a lot of them will, over time, will say, I'm good. Don't really want anything. I'm happy.
What are their risks, though? Don't they have increased risk of osteoporosis and other things?
They do. But estrogens aren't the greatest thing, but men have risk of osteoporosis as they age. Right. So it's not necessarily, estrogen originally was the only drug we had way back in the day, but now we have other things. But honestly, again, and people are going to go, could you quit talking about exercise? Exercise is probably one of the best things you can do, weight-bearing exercise, and it can just be walking. Yoga has been proven to help with osteoporosis. And we also have other drugs that can be used for decreasing risk of osteoporosis. Vitamin D, I always recommend vitamin D. And my goal for vitamin D should be around, I usually say 70 to 90 is my goal. The range on the medication, the range on the lab is usually 30 to 100. But if you can get somebody up in that higher dosage range of vitamin D, it's going to carry that calcium into that bone. And that's what you need.
Great, yeah. There's a lot of vitamin D deficiency.
Yes. And we try to stay out of the sun. When we tell you to put sunscreen on, and then we tell you to stay out of the sun because it'll keep your skin looking better. And when we put that sunscreen on, which we do need to use, we just blocked your vitamin D production. Gotcha.
All right. Well, if you have another slide or two, but we got a great question. I know this is on on the minds of a lot of people. And this one is from Debbie. How does menopause differ for breast cancer survivors who keep their uterus and ovaries?
So it depends. So I might be talking out of school because that's, again, not my field necessarily, but just because I do a lot of genetics and I work a lot with Dr. Zunzunegi and Dr. Pierce and those guys. So if you have an estrogen receptor positive tumor and you're premenopausal, they sometimes will recommend removal of the ovaries. Because they're trying to decrease that risk of that estrogen production. If the patient chooses not to do, and if they don't do that, if you choose not to do that, sometimes they'll talk about a medication called tamoxifen or Novadex, but tamoxifen. You'll hear about people being on that until they go through menopause. And then once they go through menopause, they'll usually put them on an aromatase inhibitor, like a Arimidex or something like that. So tamoxifen has its own issues. It will give you hot flashes when you're taking it. And it will potentially have an effect on the uterus. It can increase your risk of uterine hyperplasia. It can cause you to have uterine cancer. So occasionally you'll see us in conjunction with the oncologist. They'll say, they'll call me and they'll say, hey, I have Miss whoever, and I really need you to take her ovaries out. And we'll sometimes just take the ovaries and leave the uterus, and so that they can go ahead and get the patient on the aromatase inhibitor, which they feel is a better treatment. But those, it's different for different things. You kind of have to marry the treatment for the patient, and it depends on, we have patients who are in their 20s or 30s with breast cancer, and it might be a fairly aggressive breast cancer, and they'll have us remove the ovaries after talking to the patient if she's done with her childbearing and that kind of thing. So estrogens can affect your breast cancer risk, and it just depends on how you're going to have treatment and what kind of treatment.
That's a great answer to a complicated.
It's a very extensive question.
Well, I think it's your point is well taken, that it's very individualized, and you need to have a great relationship with your physician to talk about, because you'll need to know your family history. And for Debbie, I hope that you have that relationship, or whomever you're asking for. My sister happens to be a breast cancer survivor who still has her uterus and ovaries, and she's constantly having everything checked because of the medication that she takes. So I think, Dr. Zeller, you would help me understand that ultrasound of the uterus and ovaries and checking things out for her is one of the ways that she manages this breast cancer survivorship, which is a great place to be, but you got to keep an eye on the uterus and ovaries if you still have them, right?
Right. And it depends. So back in the day, we used to do a lot of, and if you were on tamoxifen, you used to get a pelvic ultrasound every year while you were on it, and an endometrial biopsy. And that's kind of fallen out of favor. And now it's kind of like, if you present with abnormal uterine bleeding, then we do, or you start having vaginal bleeding, uterine bleeding, then we'll do an ultrasound and do an endometrial biopsy. But we quit doing it. Those things are not inexpensive to do, but they are also not, endometrial biopsies are not comfortable. So we don't do those much unless we really need to do it. So we don't follow people with those like we used to. There were actually studies that they did do that. But that was back when I was in residency. And so that's been almost 30 years ago. So that's not really done now very much.
Great, thank you. So we're getting some great comments. I think, Christy, your comment was for the group, it looks like. Can you guys see the comments in the group chat? Because
no,
Christy, ma'am. Okay, I wonder if the rest
that's from Hannah. Hannah said no.
Okay. So, well, we have a good comment that unfortunately at a young age, someone was diagnosed with breast cancer, but hormone positive, and it looks like thankfully she's doing well, but the chemo tipped her into menopause. And she's been on tamoxifen for 4.5 years and never had another period. And that sounds like that's to be expected, but we hope you're doing well, Christy, and thank you for your comment. And please, if I missed the question, send it back with a question. I think that was mostly for the group, and that's answering one of the other questions with your story. Thank you. We have, I think, about 11 minutes, so please continue the questions. This is a great conversation. I think we have so much to talk about. So Dr. Zeller, do you want to just take it away with a few more slides?
Yeah, so so one of the things, this is just talking about the ovaries primary source. And, just don't remember, your ovaries are not your only source of estrogen. You also get it from the adrenal glands. And interestingly enough, adipose tissue. I like to say adipose tissue as opposed to fatty tissue. So that little layer of fat you got that everybody has, we actually have a weak estrogen called estradiol. So that is sometimes why you'll see people who develop uterine cancer postmenopausally. Not everybody, but some people who develop postmenopausal uterine cancer, sometimes, but not always, they may have a little extra adipose tissue. But I've seen it in super tiny people, but that is a risk factor. We talked about the menstrual cycles will stop. For anybody, I'm just going to tell you this. I think it's the most important thing, and I try to always remind my patients of this, is if you've gone through menopause and you start having vaginal bleeding, that is not normal. You need to see your doctor. It can be from any number of things, but you really need to see an OBGYN. There will also be, like we said, less lubrication, vaginal dryness, but we have medications that we can use. There's procedures we can do. And the big other thing, and I still don't always say, your bones can become weaker and thinner, but that also happens to men too. So we always put it in menopause, but it also can happen to someone who's, we have the female athletic triad where you're super tight, you're not a Comaniche or whatever, and you're an athlete. Those women who don't have periods, who have hardly any body fat, they have increased risk of osteoporosis too, even at a young age. So it's something to consider. If you have a family history of fractures, you probably need to, in your mom, let's say your mom developed osteoporosis, you might want to get a bone density before the age of 65. If you went through menopause early because we did a hysterectomy on you, or you went through menopause early because you had premature ovarian failure, those people might want to go ahead and get a bone density. And like we said, there's tons of medications now that you can use that are not necessarily hormonal. We have one medicine that's called Avista, which actually has been shown not only to decrease your risk of osteoporosis and improve your osteoporosis and osteopenia, but also if you had a family history, real strong family history of breast cancer, you can use that to decrease your risk of breast cancer. So there are drugs like that out there. Great. But again, it's a conversation between you and your doctor, and just realize that there are tons of different options. We've got this slide. Yeah, the menopause, and remember perimenopause and postmenopause are the same. Perimenopause is before, and menopause and postmenopause are after. And oh boy, okay. So and I'm just going to tell you, I think exercise is probably the best thing that's ever helped me with menopause. And even if yoga and Tai Chi are wonderful because they are good for your bones, and even if you have problems, let's say you have plantar fasciitis or you have something, they're great for just stretching and doing those really slow movements. Tons of natural remedies. You can use vaginal moisturizers. You can use, you'll hear, and if some of you may, if you see me, coconut oil. I always tell people the kind you cook with, because the first time I heard this, I was like, where do you find coconut oil? It's over there with the olive oil and all that stuff. You can use that for vaginal dryness. You can use it for lubricant for intercourse. You can put it on your significant other's penis and then stick that in the vagina. It's okay. It will not hurt you. But the urologists have used coconut oil for years. And it's kind of getting to be more of a thing. Over-the-counter prescription medications, I'm totally cool with you using Estroven or Ambien, any of those things. If those help you with your hot flashes, it's okay. Hormonal therapy, I just really think it's a conversation you need to have with your doctor. And we didn't talk much about it, but I'm going to hit it really quick. On the bioidentical things, that's a real conversation you probably need with an OBGYN. You do not need to be getting those necessarily from someone who's not doing this all the time just because of risk. I do know people who've gotten pellets placed who still have a uterus, who no one has protected the uterus with giving medications for that. And they've had vaginal bleeding. So I really suggest on those things that you talk to an OBGYN, and just make sure, or if you have had those medications and at any point you start having bleeding, you need to seek care.
Great advice. Okay, well, we have a couple of really great questions. I know you have a couple more slides, but I think we've touched on
Pretty
most
much
of
everything
on the slides. So, have you prescribed Paxil to manage menopause symptoms?
Have I, or do I?
Have you, and do you? And I think it's called by another name when you use it for menopause.
It used to be called Brisdale, and it was a different salt of the Paxil. So it wasn't actually paroxetine that you normally use for anxiety and that kind of stuff. But it's an SSRI, a selective serotonin reuptake inhibitor. You said that 10 times fast. But on that, you can use that drug. And I just always have to give my patients options, and I talk to them. I have people who were on Brisdale or went from Brisdale because their insurance wouldn't pay for it and are on Paxil. Yes. I always caution people, Brisdale is different than Paxil itself, because Paxil can have weight gain and Brisdale was supposed to be weight neutral. So I always just warn people about that. But any of the SSRIs can be used. I mean, Zoloft can be used. A lot of times people use Effexor. Other drugs that are sometimes used, like I told you about the clonidine, not the Klonopin, but clonidine. Some people use gabapentin, which is Neurontin, for hot flashes. So there are a lot of different things that are used off-label that can be used for hot flashes. And honestly, I do try to use those kind of things first if I can, because I want to not give my patients the risk that they can have with hormone replacement.
Great, thank you. Another great question, is menopause different for women who did not have a pregnancy during their life?
I don't think so. I would say it really wouldn't matter one way or the other. Now, speaking about someone who, I don't have a child, so I can't really speak to, and I'm currently, I'm pretty yet. I'm the only OBGYN in town that's gone through menopause, besides the one who's not practicing anymore. That's kind of, I can't even ask even my friends. I keep telling them, the girls I work with, I go, I cannot wait till you go through menopause, because this is going to be so much fun for me to sit here, because they've lived through my hot flashes and they make fun of me. But technically, it really shouldn't matter if you've had children or not, because it's just the loss of the ovarian function.
Gotcha. Okay. So really good questions coming in. I'm 49, I've not missed any periods. In fact, they're getting heavier, more painful, and closer together. I've not had any hot flashes, but do get hot at night when sleeping. My menstrual migraines are increasing in frequency, duration, and intensity. Are these symptoms of perimenopause? And can you recommend, Dr. Zeller, anything to help?
Yes, they're symptoms of perimenopause. And so what happens in general, for some people, and not everybody, cycles can get more irregular and come closer together. And then over time, they will spread out. Now, sometimes that perimenopausal time will be abnormal bleeding will be because, or the closer together and kind of thing, like you might have a period and have another one in 2 weeks, that kind of thing. It can be from an ovulatory bleeding. So you're not ovulating every month. So you're not releasing an egg every month. So what happens is that lining builds up, and if any of you were my patients, you probably heard this 5,000 times, that lining can build up and it just kind of does its own thing, and you bleed, and you can bleed really super heavy. And it's not uncommon for us to have people who will come in. I mean, very frequently, I'll have people who come in who've been bleeding for 30, 40 days, sometimes 60 days. And almost every time I'm like, was this the first time your cycles were, were they getting closer together? Were they, I skipped, or they were getting closer together and then I've just started bleeding and I can't stop it. You probably just need to see physician, an OBGYN, so they can manage that and they can help you manage it. Sometimes it's with birth control pills or some other hormonal therapy like that. But it depends on what your risk factors are. If you smoke, we can't use that over the age of 35. If you have severe migraines with aura where you see spots, we can't use that. But there are other things we can do to help manage your bleeding and sometimes the pain.
Okay. Thank you.
And it doesn't always lead to surgery, by the way.
Good to know. Well, we have really, we're out of time, but we have some great questions. If you want to stay on, we probably can get these answered pretty quickly. What about evening primrose for hot flashes?
Usually, I don't have a problem with you using evening primrose. If it takes care of your hot flashes, go for it. I've just never heard a lot of people using it for that. Most of the time, we use it for breast tenderness, breast discomfort. Like somebody comes in who's premenstrual and having breast pain, a lot of times we'll suggest evening primrose oil, but I don't have a problem. And by the way, for you, those of you who don't know what it is, it's a tablet. It's a capsule or tablet you take by mouth. You do not rub it on your breasts. I always have to remind people of that. So, but it's used very commonly for breast pain. But if you want to use it and it helps you with hot flashes, I say go for it.
Watch the dose, though. I tried some of it and I got too high of a dose and it made me have horrible nausea. So as with any new medication, if you're trying it and you develop some side effect, it could be that medication. And I just needed to decrease the dose.
Yeah.
So how about this? Someone is writing that she had hysterectomy with removal of both ovaries at an early age, 21, and has been on hormone replacement for 26 years, currently on Elestrin. So is it best to gradually decrease that, mimicking the natural menopause process? And if so, at what age?
So she's probably what, 40s?
47.
47. So I would say, at any time, I would just try and use, because she's using a topical. It's like a pump, and you rub it on your skin. So with that, she could do a little less of a dose or use it every other day. But over time, and not do it fast, over time, decrease it. But let's say she came in and she was 65. I would be going, okay, hon, we've definitely got to decrease this. In 46, 47, I'm not really worried about it because that's still, she'd be still like the regular perimenopausal time. But if she would like to try and decrease it, that's okay. There's also some feeling that some of the topical things that are FDA approved, you have to understand some of these things that are topically are FDA approved, like some of your patches and that kind of thing. Some people feel like there's slightly less risk of stroke, slightly less risk of blood clot, slightly, not none. It doesn't really change your risk of breast cancer or anything like that. But because it doesn't have to make a first pass through the liver to be active, because when it goes to your skin, it's metabolically active. So you theoretically are taking a less dose of a hormone when you're using some of those topical things like that.
But she would have menopausal symptoms when she starts to wean off, right?
Right. Well, not necessarily. If she weans off slowly, she might go, and she might not choose summer to wean off. She might choose winter.
Good plan. I like it. Okay. So are there any long-term post-menopause, let's see, the hydrothermoablation? Do you know of any long-term post-ablation factors to consider? And again, I think you said that you don't do that, so you're not an expert in it.
Are you talking about for endometrial uterine ablation, I'm assuming, where you burn the lining of the uterus?
Okay, yes.
So when we do that, you have to I have very strong conversations with patients. I'll tell them, once we ablate the lining of the uterus, if you present with abnormal uterine bleeding, we can't always evaluate that. So we can't always get to where that pocket is. So we cannot make sure that you don't have uterine cancer or those kind of things. So we have a very long conversation about what to expect, that kind of thing. Also, really, if I have a patient who comes in who's had ablation and they're having hot flashes, we discuss all the different options, especially non-hormonal, because I don't want to increase her risk of uterine bleeding, which I can't necessarily evaluate, or her risk potentially, if she took unopposed estrogen and she still has that uterus, even though it's been theoretically ablated, if you give her unopposed estrogen, you're increasing her risk of uterine cancer. So there's some conversations that have to be done. And so we usually talk about what the different things are and what the risks are.
Mm-hmm.
But ablations are really common. You know, another thing that's really kind of the new thing to do out in California, they do it. I've heard of, and I've done it here. Placing an IUD, like a levonorgestrel, like a Mirena or Liletta, in a perimenopausal female who wants to do hormone replacement, or even, I've actually done it in a postmenopausal lady who said, I really want to continue my hormone replacement, but I'm bleeding. I'm having bleeding problems. And we've done the DNC, we know, but every time she goes back on it to manage her symptoms, and that was a very niche patient. It was we had I was like, it's kind of off label, but we had a real good relationship and a good discussion, and that worked for her and has done great for her.
Good. And I apologize. I was confusing the vaginal rejuvenation with the hydrothermal ablation. That you absolutely do, and you are an expert at that. So thank you.
Yeah.
So we really are out of time. We have 2 questions that are probably very brief. Thank you so much for joining us. And if you need to drop off, you can always reach out to Tanner Facebook with questions, and we'll try to track people down. My recommendation would be to find a GYN that you, as Dr. Zeller said, can have a great relationship with and really talk about what your goals are, and then that would be very good for you to individualize your treatment. But briefly, there's a slide up now that says that hormone replacement therapy can lower the risk of colon cancer. That's a new one on me too, and someone asked, can you explain that?
So no one really knows why. They saw that in the Women's Health Initiative study. So that was that Women's Health Initiative study that was done. It's been, it's probably been 15 years ago or more. And what they did was they just had different endpoints, and that was the one thing they saw. Its hormone replacement did decrease your risk of colon cancer, but it also increased your risk of heart disease, stroke, and blood clot. So, and in certain instances, also increased your risk of also breast cancer, depending whether you used progestin with your estrogen. So right. It's not a huge decreased risk. But I'll also say about most of our studies too, and this whole thing lowers the risk of macular degeneration. I saw that, but they didn't give an indication why. They just said, we kind of saw it, but we don't really know why it did. And it wasn't like a huge, didn't like go down to nothing. It was like a couple percentage, points.
It's fascinating. I mean, we know estrogen definitely has some positives, and there may be that may be why we see some differences in disease patterns in men and women. That's fascinating.
But we also pick out different people to put in our studies. Anytime we're putting somebody in a study, we have already invested in the study people who are interested in their health. You don't go into a study if you're not doing the things you're should be doing or post. And so are we changing that by doing that? Are we given a different answer because we've made a bias in our study?
Yeah, that's a great point. All right, last question. Is there any truth to the early period, early menopause pattern?
I've not seen that.
Okay.
No. I actually have seen it the other way. So I had early periods and I had late menopause. So, I've heard that all when I was growing up, but it's also the same thing I've also heard. You're going to do what your mother did, or you're going to do what your sister did.
Right.
Not necessarily.
Good to know. All right. Any final words of wisdom from you, Dr. Zeller? Thank you so much for your expertise. This has been great. I hope that everyone has enjoyed it.
I would just say menopause is not the end of the world. I can totally tell you some great positives about it. I don't ever have to worry about, do I have tampons? Am I going to have a problem? I can go on a vacation whenever I darn well please. So there are some positives about it. It's just, it's a natural progression. And it's something that's going to happen to everybody. Eventually you should stop having periods. you eventually will have, one way or the other, menopause. And it won't always be a hot flash. And you will not have bad hot flashes all the time. I think attitude makes a big difference too.
Yeah, great. Well, thank you. And thanks again, everyone, for joining us. I hope you enjoyed this. Coping with Menopause. We really appreciate your attendance and have a great night. Thank you, Dr. Zeller.